This is Dr. Bess Miller, and I'm here with Dr. John Nkengasong. Today's date is October 30th, 2017, and we are in Atlanta, Georgia at the Centers for Disease Control and Prevention. I am interviewing Dr. Nkengasong as part of the Oral History Project, The Early Years of AIDS, CDC's response to a historic epidemic. We are here to discuss your experience during the early years of CDC's work on AIDS, the acquired immunodeficiency syndrome. Dr. Nkengasong, do I have your permission to interview you and to record this interview?
Yes.
John, you have been a visionary with respect to laboratory research and capacity building for work on AIDS and the AIDS virus in the United States and especially in Africa. In 1996, you were asked to create a retrovirus laboratory in the CDC HIV/AIDS field station in Abidjan, Côte d'Ivoire, so-called Projet Retro-C. This would be the first of its kind in Africa. Then in 2005, you came to CDC headquarters to head up the newly formed International Laboratory Branch of the Global AIDS Program, the CDC implementing arm of PEPFAR, the President's Emergency Plan for AIDS Relief. This involved providing leadership and oversight for all lab activities in all 41 PEPFAR countries, which were primarily in Africa as well as Asia. During this period, you had a lead role in forming the African Society for Laboratory Medicine and served as first chair of its board of directors. You have been a prolific researcher with over 200 peer-reviewed publications and have been editor-in-chief of the African Journal for Laboratory Medicine and a board member of many journals, including Expert Reviews in Clinical Immunology. Most recently, you've been chosen to serve as director of the newly created Africa Centers for Disease Control and Prevention in conjunction with the African Union in Addis Ababa, Ethiopia. We have a lot to talk about.
Indeed.
Let's begin with your background. Would you tell me about where you grew up and your early family life, and then where you went to college?
Yeah, thank you, Bess. I'm pleased to be part of this oral history of the HIV/AIDS epidemic. I was born in Cameroon, and I attended my undergraduate school at the University of Yaoundé, Cameroon. And in 1988, I actually had a privilege to meet when I was doing my internship at the medical school with Peter Piot. And I went over to Antwerp to study virology at the Institute of Tropical Medicine and subsequently stayed there for a PhD at the School of Medicine at the University of Brussels. So I spent quite a good number of my formative years at the Institute of Tropical Medicine in Antwerp, Belgium.
Tell us a little bit more about your childhood. What was your family like, and how did you know that you might be interested in science?
That's a very interesting question. I have a very interesting childhood story because it's unique in the context of Africa setting where the tendency was for so many families to have many children. So I was the lone child of my parents, and I was actually born when my mother was 55. So that was and I was the only child she had, and it became a partnership with her and me that lasted until she died at 103 just 4 years ago.
That is unusual.
Yeah.
And were you a good student? Were you from a wealthy family that could afford to send you to school? Was it unique to be going to school?
Absolutely. It was. I'm forever thankful to the government of Cameroon for providing free education right up to university. It was really free education. All you needed to do was to go to school and perform, and you kept what they call primary education, what here would be the equivalent of elementary school. and up to middle school and university. To the extent that in high school and university, if you perform well, you were actually given a stipend. I mean, a monthly stipend in addition to housing you in a hostel. So the system was designed to encourage education, and those students that were guided and had a family setup that could encourage them to go to school actually went to school and subsequently to college, literally free of charge.
So were there uncles and aunts or cousins that you knew that were intellectually directed? Were there doctors in the family?
No, that is it's very interesting. I count myself fortunate in many ways that I didn't grow up having uncles and brothers or siblings that had gone to school. So I literally figured out my way and in many respects. So because I was the lonely child for my mother, she decided to take me and inserted me in amongst her sister's children. Her sister had 6 children. So that I should have that environment of growing up with other siblings there. So that's how at least I got siblings, and I was not stigmatized like not having siblings. So then you literally just followed the flow. You went to school, you competed with others, and you wanted to get a score well in mathematics, physics, or whatever. And subsequently, you just moved with the flow. I don't think there was any inspiration to become a scientist. You just you went to school and you did the minimum or maximum to get going.
That's fascinating. And your cousins, did they go off to college?
Yes, some of them went up to college, but not all. Just because, I mean, I had this drive for, maybe it was my unique situation, which I was always aware of. I was always aware that even though I was growing up with my cousins, I didn't really belong there biologically. So it gave me the extra sense of working hard and always trying to be the best to prove myself always there. So that really helped me a lot because of my 6 cousins that I had. Just one of them went to university. The rest of them, even though they had more privileges and in terms of economic possibilities to go to school, they didn't take that advantage to go to school.
So interesting. So when did you get interested in the sciences? Was that in college or before college?
It was actually in what you call the elementary school. What in Cameroon at that time, they referred to it as a secondary school. Because, I mean, the education system was designed that you spend 7 years in primary education, then 5 years in secondary school, and then 2 years high school, then university. So that was the design. Now, when I got to the secondary school, I developed a lot of interest in biology, physics, chemistry, mathematics, and that's where my scientific interest developed. And the teachers were very encouraging. And then we grew a positive competition amongst a group of kids that were inclined to do the sciences, and we were almost competing amongst ourselves. And I believe that is where I carried through to high school and to university.
Now, you met Peter Piot when you were in secondary school, is that?
No, I met Peter Piot when I was I had graduated with a bachelor's degree in science, and
Okay.
I was doing an internship at a medical school, and he came in 1987 or so for an STD conference. And before that, they had they were attending a conference in Stockholm on HIV where a strain of HIV was reported from a Cameroonian. And this virus was called HIV group O. And at that time, they used to name it AN70 because it was isolated in Antwerp, and it was isolate number 70. So his purpose of coming to Cameroon was to expand that collaboration and establish it so that they could explore the prevalence of this strange virus in Cameroon. So when he came, he saw me, met me in the laboratory, and I was working for Peter Ndumbe, Professor Peter Ndumbe's lab, and he developed an interest. He said, this young man seems to be very engaged. He could come over to Antwerp and read a master's degree in virology, and that will help strengthen the collaboration. And that's why I left a year later to go to the Institute of Tropical Medicine.
How fortuitous.
Yes, yes.
Yeah. So you went to medical school in Cameroon.
I went to the Faculty of Science in Cameroon.
And did you know you were interested in laboratory medicine at that time? How did you move from the human to the laboratory
Yeah, that's a
direction?
very good question. The truth to that is that I didn't know. I mean, then when I graduated at the age of 21 or 22, the world was still very open to me to explore, and the reason I went to the medical school there to do an internship was that there was an opportunity to work on hepatitis B, to look at the prevalence of hepatitis B in pregnant women in Cameroon. This was a project, so I offered myself as an unpaid internist to work on that project. So I developed the interest in. So I developed an interest in immunology to understand what I was doing. We were doing basic ELISAs, but I had a strong interest to read immunology of what that meant and the antigen-antibody relationship. And that's how I started shifting from just basic sciences to virology and immunology.
That is amazing. So the opportunities in Cameroon sound like they were pretty good then for school in Africa. Would you say that in terms of laboratory training?
Yeah, the school system at that time was, I believe, I would characterize it that it was pretty good, because in high school my teachers were all Peace Corps. I mean, I had 4 Peace Corps teachers in mathematics, physics, biology, and chemistry, and so I owe a lot to my science being thanks to the Peace Corps that taught me in high school and actually ingrained me to becoming to developing the interest in university. So at that time, I would say the school system was fairly solid. Cameroon, as a young country, was still relying on a lot of expatriates from France and from other European countries to be lecturers at the university, because they had not trained enough people to take on senior leadership at the university. So even at the university, a lot of the professors we had were from France in particular, and of course some young Cameroonians that were coming up after finishing their studies in Europe. So it was a very strong educational system that we had at the unique university that they had at that time.
Mm-hmm. So then when you got to Antwerp and the Tropical Institute, was that a big jolt for you? Was that amazing? Had you getting to Europe and getting a very different environment scientifically? What was that like?
It was amazing and life-changing experience in many respects. One, the size of the class was extremely small. We were only about 20 in our graduate program. So you could literally sit around the table and interact with your lecturer or teacher, which was not the case in my undergraduate, where the teacher was very distant and you found it difficult. There was this barrier between you and the professor because the size of the class, we were in about 500 to 600 in a class. And then suddenly you are in a classroom with about 20 people there. So that was one. Second, the facilities to an enabling environment to study. The library was open most of the time, including weekends. You had top journals that were published each week, and they would store it in a small room for people to go visit before they put them on the shelf. The librarians were very cooperative. They wanted to give you anything that you wanted, any paper that you requested within days, they would give you that. So it was just unbelievable change in the facilities and exposure that we had there. Then the most striking thing was the ability to enable you or to force you to think yourself. not direct you, not being directive there. Like when in Cameroon, you expect the teacher to say, well, you have to do these things. When I got to Antwerp, I remember my first meeting with Peter Piot was, his first question was, what is your interest? What do you want to do in the lab? And I was like, what? You tell me what I want to do. You tell me I'm here to learn. And it took a while for me to learn that, I could develop my own ideas, my own hypotheses. And so that was the beginning of developing my scientific skills.
So you ended up getting a doctorate was it in retrovirology or
in virology?
Virology in general?
Yes. So it was interesting when I initially went to Belgium through the Belgian Cooperation Scholarship. So after 1 year, I did very well, and Peter Piot came to the lab, and I remember him walking into the lab and said, John, you've done extremely well here, and we think there's an opportunity from the Belgian Corporation to give you a scholarship for another 4 years to do a PhD. And I was totally surprised because I had planned to go back to Cameroon, and that was never part of my arrangement. And I was missing my mother. I wanted to go back and meet her. And I said, for how long would this program be? He said, for 4 years. Come on. I was like, no, this is too long. Would I be able to go back? And in between, I said, yes, we could design some projects that you go back to Cameroon. And so that's how I ended up doing a PhD in virology.
And what was your emphasis for your PhD in virology?
My emphasis was on characterizing strains of HIV in Africa, both the biologic, antigenic, and virologic characterization of HIV strains. So we look at the HIV strains at that time, which was very fascinating. At that time, there was, remember, we are in the 1989 time frame, and HIV was broadly known to be either HIV 1 or 2, and within HIV 1, there were two types. I mean, they were called North America and United States strains, and then the African strains. That's all. That was them. But we knew that beneath that there was something different. Remember I said earlier that there was a strange or an aberrant virus that was isolated in Antwerp called AN70, and it ended up being classified as Group O. So we knew that given the diversity there, HIV could not just be simply divided there. So my PhD thesis was, first of all, to characterize the different genetics subtypes of HIV that existed in Africa, and then look for the biologic differences, and or ask the question if there were some biologic differences that existed between the strains, and then ask the question if there were some neutralizing properties between one type of virus and another type of virus there. So that was my entire spectrum of a PhD in 4 years. Mm.
Well, you did some things between these, but in 1996, you were asked to create and direct a laboratory in Projet Retro C, which had been established earlier in 1988. And that was a large field station sponsored by CDC, sort of initially to look a little bit more into HIV-2, but then, of course, went on to look at many, many aspects of the epidemic. Can you tell us a little bit about what you were thinking when you took this position, and what were the circumstances on the ground when you got there?
Yeah, interesting. And as I said earlier, when I went to Antwerp, I used to go to the library every Monday to look at new journals and new publications, because I was on top of everything, and I mean everything that was published in Africa, be it in epidemiology or lab. It wasn't just in laboratory, but nearly everything. And there were certain researchers that I was tracking in Africa on what their work was, and especially in Kenya, in Cote d'Ivoire, and of course in DR Congo, at that time called Zaire. So in one of my Monday visits in the library, I took the Lancet, and I saw that a position was advertised there they're looking for a virologist to run a virology lab in Abidjan for CDC. And at that time, I was already the chief of the virology lab at the Institute of Tropical Medicine. I had done my PhD there, and Peter Piot named me the head of the virology lab there. But I was eager to go back to Africa. I haven't spent about close to 8 years in Europe. I thought it was time to go back to Africa, and I was very, very interested in the work CDC was doing, because we used to be almost like competitors. We know that Masha Kalish and others and Jerry were doing work on subtyping, and we were also doing work on subtyping in Antwerp. So we tracked their work very closely to understand what they were doing. And so I developed an interest in the CDC's work there. So when I saw the opportunity in Abidjan, I immediately applied by fax. I remember taking that and going back to the lab, I wrote an application and just went to the fax meeting and faxed it to Cote d'Ivoire. That's how it all started. And then weeks would pass. I didn't get any reply. And then one day the secretary called and said there was a phone call for me from Abidjan. And I took the call. On the other side of the phone was Alan Greenberg. Alan Greenberg was the director of RetroC at that time, and requested to talk to me, and started off by saying they've seen my application and my CV. They're interested in talking to me. So, and then arranged for an interview at the airport in Brussels between me and Mark Rayfield and Dale Hu. So
Mark Rayfield and
Dale Hu.
Dale Hu.
Yeah, they were in Abidjan providing technical support to the field site, and on their way back to the United States, they stopped in Brussels, and I came in and we sat at the airport and had coffee, and they did an interview on if I had the interest or the qualification, and it was a very detailed technical interview, like how many PCRs have you done, how would you set up a cultural laboratory, and those were things I was doing in Antwerp then. So. And that's how, weeks later, I received an offer that I should come to Cote d'Ivoire, see the position, and if I like, they would be happy to offer the position to me. I went to Cote d'Ivoire, and Alan Greenberg took me around the building, and this building, Projet RetroC, was within the infectious disease clinic of the University Teaching Hospital in Trècheville, and showed me an abandoned building. That building had been abandoned for years. It used to be a place that they quarantine patients there. And the government of Cote d'Ivoire had offered that to Projet RetroC, to renovate for a virology lab. So there was really a contrast between what I've read in the Lancet about starting a virology lab and then a virology lab itself there. So he pointed to the building and said, "John, I see a dilapidated building, but I see a virology lab there." They look at me and say, "What do you see here?" And I said, "Yes, I see a virology lab." But to be honest, I was completely discouraged there. This was not a lab. I was working in the lab, publishing in Journal of Infectious Diseases, Journal of Virology. Then I'm looking at this like, how am I going to start doing this? Yeah. So it was, but I saw in him the seriousness and the commitment that he was ready to support me to get the lab started. So I went back to Belgium, convinced my wife, and we took a 1-year contract.
Oh, you had a wife at that time?
Yes, I have a wife at that time and a son, 3 years old. And we took a 1-year contract to come to Cote d'Ivoire. And my wife was devastated, said, "You must be stupid. You live in a full-time job in Antwerp. You are chief of the lab with about 20-something people working for you, and you're going to Cote d'Ivoire with a 1-year contract." And I said, "Look, dear, if we go there and we do this well, there's no reason why after 1 year, if we do the job well, we will not continue to do the job." And they would extend this contract. And so that's how it happened.
So why a virology lab in Abidjan, Cote d'Ivoire? What was their thinking and what was your thinking about that? Was that something that was needed for Africa? Was that something to prove that you could do it in Africa? We'll talk later about the general, but maybe even now you can tell us a little bit about the status of laboratory medicine in Africa at that time.
Yeah, I think it's fair to say that at that time there were so many things that CDC was doing in Cote d'Ivoire at that time. And remember, Projet CEDAR had just collapsed. Yeah. Shortly after, and they were really looking for a state-of-the-art facility to do many things there, including understanding the differences between HIV 1 and 2, understanding the dual infection, HIV 1 and 2 dual infection, understanding mother-to-child transmission of all. So they were actually shipping specimens to Antwerp, to the lab that I was working previously for virus isolation. Remember, there was no PCR at that time, actually, specific for HIV. So culture was like you have to culture the virus, which means you isolate the cells, preserve them in liquid nitrogen, ship them to Antwerp or to Atlanta, and then hope that this whole process goes on well so that the cells are still viable for you to isolate the virus. Most of the time, when the cells got to Antwerp, they were dead. They were dead cells, so it became a wasted effort there. So I think the idea was to have a state-of-the-art laboratory in place that you could do all of those testing and analysis locally in Côte d'Ivoire and avoid shipping specimens. And the second concept or idea was to build local capacity. That, I mean, if you have a state-of-the-art lab, you could actually build local capacity, support the studies that were on. It would be quicker for interaction between the epidemiologists and the lab to interact and shipping specimens to Atlanta or to Antwerp for testing. I think that was the rationale at that time. And now, in entire sub-Saharan Africa, there was no lab that was doing that kind of work, that was doing...
So nothing in South Africa?
In sub-Saharan Africa. South Africa, the National Institute of Virology, at that time it was called, now it's called the National Institute of Communicable Diseases, it was called National Institute of Virology, had the ability to do that. But in, say, sub-Saharan Africa, you have nobody who was doing that kind of work. So the Abidjan lab became a state-of-the-art lab across the board.
So a challenge.
Yeah, it was a big challenge. And later on, we can talk about how it started supporting other initiatives in Africa, in Nigeria, in Senegal, in Togo.
So you get to Abidjan. Now, obviously, the French was another advantage. You speak fluent French. Yeah. You grew up speaking French, yes. I guess. How did you begin? How do you even begin something like that?
It was challenging. I mean, that's a very good question. Before I came, I arrived Côte d'Ivoire, they had a serology lab, a lab that did mainly two things. They did CD4 count analysis, and then they did HIV serology.
So again, it's 1996.
Yes.
There's no treatment for AIDS in Africa. There's the presence of antibody testing. So are people beginning to get tested in Abidjan at that time?
Yes.
So that's where you're entering and trying to set your priorities for.
Exactly. Yeah. So it was 1996, early days, HIV treatment had just been made available in the West, very costly, but it wasn't available in Africa. So everything that we did at that time in Côte d'Ivoire was studies. We were studying multiple populations, i.e. STD clinics, tuberculosis patients, doing trials for mother-to-child transmission. I needed the testing, so the backbone of all those studies was a reliable HIV test.
Okay.
And the assays were there, but they were, of course, ELISAs, the enzyme-linked immunosorbent assays, and Western blot. And you think that it was easy to be done. It wasn't, because interpreting the Western blot profile was challenging. So it took a lot of time, and there was a lot of cross-reactivity between antibody cross-reactivities between HIV-1 and HIV-2 Western blotting. So we ended up in a confusing state that people just didn't know the true prevalence of HIV-2 and dual infections there. So that was one of the main things that I started. So I arrived Côte d'Ivoire, Abidjan, and I'm embedded, first of all, in the serology lab. That was already in place while waiting to build my virology lab. So I took on that. My first assignment was, and I remember vividly that there was a site visit with Helen Gale, Kevin DeCog, Ken Castro, and Tom Folks, Jerry Scotterman. And so they all came to Abidjan to do a site review. And each department presented their priorities. And I presented my priorities for the virology lab. And remember, I was coming from a university setting, not a public health setting. So my projects that I presented were more on pathogenesis. I wanted to look at the pathogenicity of HIV 1 and 2, compare the two, look at how immunologic activation in Africa could contribute to disease progression and all things like that. So at the end of the, the 1 week retreat, they pulled me aside and they said, John, you're a very bright young man. I was like 34 at that time. Said, we think you should focus and try to help the serology lab to identify a good testing algorithm for the lab because they are struggling to do proper diagnostics with quality assurance. So my reaction was, what? So you think I came from Antwerp to be doing basic serology? I mean, this is, you want to ruin my career. That was just, my natural reaction was like, this guy must not be. But anyway, fast forward, we did, I took it seriously. I started analyzing different assays that we could use to eliminate Western blot from the test combinations. And we did, my first evaluation was based on about 9,000 specimens there. And it came out with one of those striking results that we submitted a paper to AIDS. We never heard from them. And we realized months after, I remember the old days you submitted hard copies and you wait for months. And then months later, we found out that it has been published without comments. And there was an editorial written on it that, this was a fantastic work on serology and whatnot. That's the only paper I've published with no comments from the reviewer. And that was based on that, the serology. So that became the standards that we gradually took off Western blot and started using a combination of ELISAs there. So,
and by the way, 9,000 specimens. So there's a real machine going on out of Projet Retro C that's acquiring specimens. And
yes,
it's a big operation that you've entered.
It was a big operation. When I came to I joined Retro C. They were testing about 35 to 40,000 samples a year from different populations because it was mainly surveys and epidemiologic studies. They were from all kinds of populations, the sick patients, the children's population, and so there were a lot going on there. So I designed that study in two ways. One was a cross-sectional study where I just took about 1,500 specimens and checked 5 assays and see which ones were performing better. Then I took about 3 of them and let them run for 1 year. So within a year, we could analyze about 9,000 samples and then use that to really tease out which assays were performing better. But it became the standard. That's how we knock off Western blot from our testing algorithm. That led to a lot of cost savings and simplified the testing process in Cote d'Ivoire. So that was my first thing that I did on serology in Cote d'Ivoire. And
who was working for you? Were the laboratory personnel that were managing these studies Ivoirians? Were they from CDC Atlanta? Who were these folks?
All of them were Ivorians. And my colleague who was running the serology lab was Chantal Maurice, also Ivorian, but had been trained a lot in France, exceptionally well trained, senior professional. Underneath her, there were about 25 technicians, all of them Ivorians there. But none of them had any exposure to work in the virology lab. So I literally had to start from zero, recruiting people that could work in a virology lab, do virus isolation, also introduce them to polymerase chain reaction PCR testing, because none of that was going on in Cote d'Ivoire at that time. So gradually, I set up the PCR testing in the lab. And when we did our first PCR results and it was positive, I remember Alan Greenberg, somehow he knew that I was experimenting that to set up, and someone had told him he bought a bottle of champagne, came to the lab, and we popped that in the lab because that was the first time PCR was done in Projet Retro C. So that was the beginning of that. Then gradually, the virology lab was built, and then we transferred the technology into the lab. And then I had hired about 5 technicians to work for me, and we moved over to the virology lab.
So did that take years?
It took about 2 years to get from the time we built a lab to the time it actually went operational slowly. Then I went to France and Belgium and started looking for Ivorians that were out there with a PhD or postdocs to bring them back to Côte d'Ivoire. Like Christian Adjei was just about to finish a PhD at the Catholic University of Leuven in Belgium. So I went there and to kind of scout, do kind of intelligence around her, and finally brought her to Côte d'Ivoire. Stéphania Kovlavi was at the Institut Pasteur in Paris. We also brought her back to, so that's how we started building a team of at least mid-level Ivorians who were scientists who could support me in that initiative.
So you didn't leave after a year, and you told your wife you might leave after a year, but then you got into it. So for someone who was kind of a deep-thinking scientist, were you kind of moving into more of a sense of mentoring and creating something in Africa? What were you thinking about as you were sort of getting excited about the work in Abidjan?
I think there were 2 things that, as we settled into my first year of contract, were occurring to me, that the opportunities that existed there to do good science, that I was beginning to learn public health, what it was, because I had no clue of what it was. I was a basic scientist at the Institute of Tropical Medicine. I was looking at epitopes, genetic subtypes, and not relating it to the patient at all. I mean, I would go to the lab and see a virus that has switched from a syncytia or non-syncytia inducing to a syncytia, and I'll be excited. I mean, that virus changed and whatever. So in Côte d'Ivoire, when I joined CDC, it was more about a test for a patient, and what does that mean, and how do you do quality work to advance that. So I saw that opportunity to grow in public health. The second thing that was uniquely lacking was the rigor, the professional rigor of the staff that was there to really understand what it meant to exercise quality around the test. They did their work, but it wasn't like it was where it has to be. But I saw also an opportunity where they were open to learn, and they needed that mentorship there to bring them back, to bring them to the level that I expected, especially the standards that I was used to working in Belgium there. So that's why I thought, John, you can only succeed in this endeavor if you grow a team around you of people that you can mentor and bring their standards to where it has to be.
Who was mentoring you during that time period? Who did you look to for guidance on? There were so many decisions you had to make in terms of how to prioritize and how to mentor. Do you remember some people that you looked to at the time?
Yes, at the 2C itself, it was there were 2 people that were instrumental in that. Not truly as lab mentors, because there was no lab mentor. I was a senior lab person at that time, at maybe 34 years. That was, I mean, but the rest, the team was pretty young. I mean, Alan Greenberg was probably a little bit older than me. Stefan Victor was a little bit. So Alan Greenberg and Stefan Victor were the people that, I mean, I would bounce ideas with. They would rein me into how to align my write-ups to make it look public. Like I would start up like describing my specimens. I didn't bother where they came from. I didn't bother where the years that it was collected. I mean, for me as a virologist, how did that matter? I was interested in virus, and they would say, "Well, John, this abstract it's good, but you have to say that between April 2000 and April that you collected this mail from women, and it was systematic." I said, "God, how is this important there? I just like to work on the virus, not on this thing." But those were the people that really mentored me to. And guided my first steps into public health virology, as I would say.
Yeah. So it's 1996 up to 2000, which I think was a kind of a watershed year in terms of thinking about getting ART into Africa. So it's a mess. It's a nightmare. It's a terrible epidemic. There's people dying, funerals every weekend. How did that affect you? Were you kind of cloistered in your lab away from the disease and death in the city, or was that everywhere?
It was a life-changing experience. Because when they finally constructed my virology building, my office was overseeing the infectious disease clinic of the hospital, the main hospital. And literally, I could sit there, open the window, and see people come on with a taxi, pull out their loved ones and dump them there, and people dying and shouting and crying. And they were all HIV patients. That was to the extent that some days I would just shut off the curtain and just not to be seen. It was very stressful to see that that it was real, that this thing was, it was not in Antwerp where you never saw an AIDS patient. I saw specimens, but not an AIDS patient, but now you saw them live in front of you in very miserable conditions there. They would come in very skinny and almost in a coma because people delayed bringing them to the hospital. Of course, there was no treatment at that time. So it was a very traumatizing experience daily, to be seeing that on daily basis in Côte d'Ivoire.
Mm-hmm. Those were some tough days. Once you got the lab up and running, and actually there were some early ART programs in Africa, including specifically in Côte d'Ivoire, the UNAIDS Drug Access Initiative. There was a lot of thousands of viral load testing, CD4 counts, and so on. Can you tell us a little bit about that? Once it started really scaling up and you had a huge burden of programmatic responsibilities, how did you manage that? How big did your staff get, and did you have to say no to some aspects?
In 1998, I remember I was in Cameroon, December 1998, I was in Cameroon for my end of year holidays, and I heard that the Minister of Health of Côte d'Ivoire, Professor Nkengasong, had announced on television that CDC, Projet Rétro-C, was going to provide viral loads testing to the program, to the UNAIDS Drug Access Initiative. And the cost of viral load, there were several things that concerned me at that time from Cameroon, because I was barely called to say that, John, this is what is going on and you should be ready to. The cost of viral load was at that time more than close to about $200 a test. Secondly, there was no viral load test that was suitable for use in Africa at that time.
Why is that?
Because of the genetic subtypes. The viruses that were used to produce the viral load tests were based on what we call subtype B at that time, and not the strains of HIVs that were there. And to give you, so those two parameters were, and the know-how of even if we had the test, where are we going to do it, who is going to do it, wasn't there. But there was a big initiative there. So I came back, and the first thing I did was to go to Roche in New Jersey to understand the test that they had. I got trained on that test. It was called the Roche Amplicor test. Mm-hmm. Came back to Côte d'Ivoire and did the usual things you and I would do, evaluate it on your own local panels, serum or plasma. And guess what? The sensitivity of the Roche test at that time was 60%. So here we are supposed to scale up viral load. So we ended up working with Roche and CDC here in Atlanta to design a hybrid where the standard tests that were produced, we add in some new primers there, the primers that would correspond to the circulating strains in Côte d'Ivoire. And that brought the sensitivity up to about 96%. And that's how we started doing viral load testing in Côte d'Ivoire. So it was, and we publish all of those things in Journal of Clinical Microbiology too. It's really fascinating to see how, the things that we did. Because I tried like 2 different assays, NASBA and Roche, and they were all, they fell flat on the sensitivity side there. But Roche was smart. They did some non-B primers, and that got us to that. So that was one challenge. Second challenge was specimens were coming in, and we're doing the testing. It became clear to me that the clinicians were not using the tests because they didn't know what viral load was, about how do you interpret viral load. So I would spend hours and hours every day going across to the infectious disease clinic to provide seminars and do one-on-ones with the clinicians, and we look at the results like, okay, this patient had 500,000 copies per ml, or this locked copies, and then they started treatment 1 month ago, and it had fallen to 200,000 or locked. What does that really mean to the? So I'll explain them that what is the difference between the absolute numbers and the log copies, and so it took a lot of interaction there, a lot of seminars there to teach the clinicians there what it was that we were trying to do and how they could use that results to appropriately to manage the patient. So a bulk of the results that were done initially were not truly used for any effective patient management. So,
and what was your thinking about that at the time? So I'm recalling that as slowly as ARTs were brought into Africa, and more after, I think, 2000, but this was an early intervention. There was a lot of discussion, and there were papers and protocols comparing CD4, viral load, no laboratory, because it's not practical for Africa. What was your thinking about that? Were you wanting to prove that it could be done in Africa, or what was your underlying thoughts on doing this very complicated test?
The very first reflection was to do it the way it was done in the West. Okay, the way that guidelines, the U.S. guidelines or the international guidelines, how they were published in the JAMA at that time. Okay, so you do your first baseline viral load, and then after 1 month of treatment, you do another viral load, and then after 3 months, and every 3 months, you do the viral. So there were lots of viral loads that were done there because you wanted to meet the standard. So then we progressively started saying, well, if you really have to scale up ART treatment and you do it the way it's done in the West, you will never be able to succeed because without that support from RETRO-C. And keep in mind, the RETRO-C lab was the only lab in entire sub-Saharan Africa with a viral load capabilities. So how would you scale that up? So many people could not even do it. So we had regional meetings where we started, at that time, Michel Kazaskin, who later on became the Global Fund director. He was a professor of infectious disease in France and had projects in Senegal. So we'll convene meetings in Senegal or Côte d'Ivoire to discuss a regional approach on how do we do this with a minimal viral load and just use CD4 counts as a marker to see how this was done. This was in 1988-89 timeframe. And we had about 2,000 to 3,000 patients on treatment in Côte d'Ivoire. Senegal had about 100 patients. Everybody was learning. Okay, 100 patients on treatment. And what was the viral load results in this patient? We were all learning. So we meet, and Senegal will present their national ART program with 100 patients. Côte d'Ivoire will present their national ART program with about 3,000 patients. So by the time I subsequently left Côte d'Ivoire in 2002, we had about 8,000 patients on treatment as part of the UN Drug Access Initiative there. So, and a lot was learned from that because we did a supplement in AIDS where we explained our experience, and I think it was really helpful in informing the way forward with how you could expand ART treatment without all the complexities of the viral load testing.
There were a number of aspects that you were able to look at. Genetic diversity, you mentioned the cell-mediated immune response, variety of serologic assays. Were you able to get some of your research interests done in the midst of all the programmatic demands?
A lot. I think that was the great fortune of being in Pajero to see. I recognized early on that I needed to build a strong partnership with the clinicians and epidemiologists and the lab, to the extent that when I supported what was required as an emergency or as an immediate priority, then the specimens were available for me to use in addressing any other question that I needed to. But the priority was to make sure that you met their needs. For example, when we did a short course trial to see how zidovudine administered at 36 weeks of pregnancy could reduce mother-to-child transmission. Later on, the specimens were there, both from the mothers and infants, for me to explore and ask any virologic question there. When we did microbicide trials in female sex workers clinics in Côte d'Ivoire, afterwards I used that to look at all kind of cell-mediated immunities, like why were they exposed and uninfected, and were there some underlying things that was, and we published a lot of that in Journal of Immunology and others there. But the first priority was to make sure that they got their lab test. That way they stayed away from, they leave you alone to go do whatever you wanted to do. So I think it was we also look at the interaction between HIV-1 and 2. And the hypothesis there was that if, at that time, the Harvard group had published a paper that said that HIV-2 protected against HIV-1, published in Science. And we said, if this is true, then for individuals who are co-infected with HIV-1 and 2, the HIV-2 can downregulate HIV-1 so that you have lower viral loads. And the way to measure that would be that you expect to see lower viral loads in people that are dually infected, because the HIV-2 is in there playing some.
And did you?
Yeah, we did all of those things, but we didn't confirm that at all. So we look at dual infection, what HIV-1 did to HIV-2, what HIV-2 did to HIV-1, and publish all of those things. But that was really like the science that, it was more pathogenesis, but we did that at the sideline of supporting the clinical trials or any interventions that was going on.
You ended up working quite a bit with WHO in Geneva and AFRO at that time. Can you talk a little bit about that, whether it had to do with lab aspects of implementing ART in other countries, setting up drug resistance networks, phenotyping and neutralization assays? How did you and how did CDC relate to WHO at that time?
I think that as our work grew in Côte d'Ivoire, in the virology lab, it was clear that we became, I'll say, a continental recognized player. So the WHO and us will work together on quality assurance programs for diagnostics. We begin to scale up HIV testing. And I think it's fair to say that outside of South Africa, no testing site, and I repeat, no testing site was enrolled in any proficiency testing program, no quality assurance. So you did your test and that was it. So the whole concept of quality management system there. So our first meeting in 1999 in Harare was to bring countries together and begin to talk about quality assurance for HIV. And colleagues from CDC here that were at that meeting included Tom Hearn, John Rederhoff, Mark Rayfield, Bob Martin. So those were people that when they were driving it from the US side and we were in the field. So had a very good meeting, brought member states together and started the concept of quality assurance for HIV testing there. So that was just one thing there. Then we moved into drug resistance. The very first network, the so-called RISNet, which is the WHO drug resistance network, I was an integral part of that when it was set up, and go to Geneva. I was part of the steering committee designing how do we work together as a network to do sequencing of viruses and detect antimicrobial resistance as we begin to scale up that. So we published a series of papers from the Drug Access Initiative with point on HIV-2 drug resistance, on HIV-1 drug resistance, and even drug resistance in the short course zidovudine triad. So that really rapidly positioned us at a very good place very early on to be leaders in the areas of antimicrobial resistant testing in Africa there.
You mentioned that no one was doing quality assurance and proficiency testing in their HIV work. What about other work? Was there much in the way of general laboratory quality assurance in Africa?
Very, very, very little. I would say. I mean, what we saw in the HIV mirrored what was going on in the general laboratory settings there. Just to put it in the appropriate context, when we started work, and this is leapfrogging to the PEPFAR years, no lab in sub-Saharan Africa, government lab, no Ministry of Health labs had any accreditation by international standards. Well, I mean, besides South Africa, I mean, it's always an exception because they had some of these concepts going on forever. But if you look at sub-Saharan Africa and government labs, none of them had it. The only labs that were meeting international standards were research labs and partner labs in like the U.S. CDC labs that were doing research, or the U.S. military labs in Kenya that were doing research. I mean, and they would bring it to international standards there. So that was it was striking. But today the whole field has changed in a dramatic way.
Before we move on to sort of another phase, it sounds like part of your work and then part of maybe your own personal feelings were that training and capacity building in Africa at some point started to be a very big part of what you were doing, and maybe what you wanted to do. Can you talk a little bit about that? Were there colleagues that you were discussing laboratory training with? It seems like it could have been so overwhelming. I'm wondering how you were thinking of that.
After many years of doing the work in Côte d'Ivoire and doing presentations across the continent, it became to me that we needed two things to happen there. One, to invest on the human capacity, to the virologists and immunologists in Africa, and to create that network as much as possible so that people in East Africa, Central and West Africa are all connected. So that was one. The second thing that drove me a lot was the lack of institutions. In laboratory institutions in Africa, there was no association of anything. Like if you came to the US, you see the American Society for Microbiology, the American Society for Clinical Pathology, the Association of Public Health Laboratories. None of that existed in Africa. And I knew that the only way to sustain our efforts was to make people begin to talk and share experiences across Africa. So I think investing in people that would share that vision was critical. So we started sending some people from Project Rétréci to be trained in Antwerp and Berkeley. People like Mireille Kalou, who used to work for me, was sent to Berkeley to do a master's degree, and then came back, continued to work there, and others went out for short-term training there. So that we started building, and each time we did this, it was a lengthy process because they went away for a year or two, but when they came back, the quality of the work increased. You were on the same page. Basic things like how to do a presentation became much better, okay? And that lessened the burden on you. I mean, we had to do basic things like reviewing slides, make sure what you say when you put on a slide there and you read the title, the axis, and then the main message, or basic things like that had to be done right there. And I think that was very, very important, because today, I mean, when we left Cote d'Ivoire, I would say that we trained about 15 senior people who are all over the continent today running programs there, from Botswana to Namibia to Cote d'Ivoire. People like Stefania, who used to work for me, is the director of ICAP, running the program in Cote d'Ivoire. Mireille Callo is a unit lead here at the US CDC, running the whole quality assurance program for in Africa for HIV. So that was a very good investment. Christiana J is a branch chief in Cote d'Ivoire, running the lab there. And then my interest shifted to institutions. I said the only way that would make this happen was to build institutions for them. And I started thinking of how do we create a sustained society for lab medicine that can truly be that umbrella that brings people together to think about laboratory medicine very broadly, and create a constituency for the continent that will drive the agenda for laboratory testing. So that's how we ended up creating the African Society for Lab Medicine.
You came back to US CDC headquarters in 2002 and served as chief of the HIV International Vaccine and Support Laboratory. But then in 2005, as the PEPFAR program was scaling up, you were selected to serve as chief of the International Lab Branch of the Global AIDS Program and as co-chair of the Office of Global AIDS Coordinator, the Washington arm of PEPFAR. You were asked to serve as co-chair of this laboratory technical working group, which had a very large mandate of looking at leadership of this entire PEPFAR program, which was a $5 billion a year effort, and look at all the lab activities in these 41 PEPFAR countries. So it was a lot of resources, probably more than you had dealt with in the past, but a lot of responsibility. Can you describe why you took this assignment and what was your initial thinking about the challenges?
Yeah. I mean, first of all, when I left Cote d'Ivoire in 2002 and came to Atlanta, I was working in the Division of HIV/AIDS Prevention, DHAP, but in quote, seconded to the lab, working in Steve McDougall's lab. And my essential role there was to support the vaccine trials that DHAP, the EPI branch, epidemiology branch, under Alan Greenberg, was doing overseas. And they were in, of course, Cote d'Ivoire was shaky because of the instability there, Kenya, Thailand, and I think we're looking at Uganda as well. So I started looking at that. I mean, supporting, and Botswana, we're doing another trial in Botswana to look at PrEP. So my goal there was to support all of this. But as we did all of this, I realized, and PEPFAR was ramping up and becoming exciting. I said, like, if I have to sit somewhere and not do science, but do support work internationally, the best place to do this was not in DHAP, but it was in PEPFAR. And so I shifted, and I remember when I took the job in 2005, people were very surprised. They say, you're a very good researcher, you've done all of this nice work. What are you going to be doing in PEPFAR? Are you going to be doing support logistic work? And I mean, it was, someone characterized it as, I mean, John, why would you put your step into cow dung? And I said, well, I think I could do that. But it was very challenging because at that time, there were not even up to 41 countries. There were 15 focus countries. And just to make sure that you put in basic serology in a way that you had accountability and quality control of those of the testing in the 15 countries was a big, big challenge. The very first thing we did, of course, in partnership with Bob Martin, John Rederhoff, and Tom Hearn and Mark Raffey, was to develop a package a package on guidance on how to do appropriate rapid tests. Here we are in 2002, 2, 3, and HIV serology has been going on forever. But the challenge that we had here was not just doing the test, was to scale up the test, okay, which was very different, significantly different from what we were doing before PEPFAR, which was limited to hundreds of thousands. Like I said, in Cote d'Ivoire, 30,000 to 40,000. Now you had to go up to 100,000 of tests doing that. So I think that was a big, and using rapid tests. So rapid tests, even though a few years before, there were only about 5 to 6 HIV rapid tests. Because of PEPFAR, I mean, many companies started producing rapid tests, and it was our responsibility to ensure the quality of that, to put multiple layers of quality there. And CDC had no process in place to ensure the quality of rapid testing upfront. And when I joined PEPFAR, and the question would arise in the country, if we knew what the performance was, we'll call a field director like Robert Downing and say, well, Robert, have you used this test? And you say, yes, it seems to be working well in our hands, and they would recommend that. So when Ambassador Bex came, at that time, Dr. Bex, the first thing we did with her was to agree that we put on a panel, an internationally collected panel, characterize it, and use that systematically to evaluate our tests from headquarters, then advise PEPFAR and OGAC on the test and the countries.
So the panel is people, or the panel is a panel of specimens?
Of specimens. These are plasma or serum that we collected from multiple countries, from Kenya, Uganda, Cameroon, Cote d'Ivoire, China, Thailand, and large volumes of them. This was blood units, because we wanted to make sure that we had enough volumes that could be used for a long period of time. So,
okay.
Yeah. So that was the first standardization. I mean, that almost looked like a regulatory process where a rapid test would come in there and we evaluate it, and it was based on about 1,500 units of blood that we had collected. Wow. And sequenced the viruses. So we actually knew the subtype of virus that was there. We knew the titer of the virus, the plasma, and used that. And I think some of that is still being used today in evaluating the test which we set up about 13 years ago.
So where was that done primarily? In Atlanta?
It was done primarily here. We collected the blood units, HIV infected and negative units across multiple countries, and shipped them here, characterized it and stored it in deep freezers in smaller amounts that we only took them out and tested.
So how many lab people did you have working for you at that time?
At that time, when I just started the lab program in PEPFAR, there were just about 10 people that we had in the lab. And fast forward, when I left last year, we had ramped the program up to about 76 people in the lab. So it was really a steep curve going up, I mean, very quickly to about 70-something. Very, very importantly, in the field, I believe there were only about 2 lab people in the field. Okay, it was Robert Downing in Uganda, and I think Jen Mwangi in Kenya. But as I left, nearly all our programs had a lab advisor in the field. We were 40-something lab advisors in the field. So if you combine the colleagues in the field and headquarters, we were running an operation, a tight operation of close to 100 and something people.
So for PEPFAR, initially you needed to standardize the rapid testing approach. What were some other priorities as you moved along, and as there was a dramatic scale up of treatment of HIV in Africa during those years and continuing?
Yeah, there were 2 tests that took a lot of our time. I mean, one, I said, was rapid testing, because without rapid testing, we would never have made any breakthroughs in scaling up ARTs there. Second test was the CD4 counts. I mean, remember, even though viral load was around, but WHO guidelines had suggested that or recommended that we use CD4 count as a marker, okay, to monitor treatment. So scaling up viral load, CD4 was also a big challenge. Now,
what's challenging about that? What do you have to do to implement? I know there was the fax counter, other equipment. What did that involve?
It was the technology and the human resource to do that. One, as you rightly said, the fax count was there, and not everybody had the ability to afford a big fax count machine. And then even if you had it, gauging it and manipulating it was not easy. You needed qualified people to do that. So as the market grew, the companies also got savvy, and then they developed the fax count, which was still using the same technology, but it required less manipulation. Okay, and then as the field further evolved, it went down to a very simple process where you just stick in a tube of blood, and then it gave you the what we call the point of care CD4 count machines. But the early days was really mainly fax count machine and fax count from Becton Dickinson. So that was also a challenge. Now, we also had to extend our drive for quality assurance from the HIV rapid testing to CD4 as well, because you had to have panels. From that, you challenge the labs all the time to do the quality assurance for the CD4.
Can you talk a little bit about you mentioned that you finally got to point of care, and that sort of that theme carries out in many lab interventions in Africa. So initially, for example, with the fax counter, would it be put in a central location, at a district location? What were some of the challenges in thinking about how to operationalize this new level of sophistication, really?
It was, when we started off with the fax count machines, they were highly centralized. So that required that you get blood from the district or the distant sites to the laboratory and tested them. And it came with all the challenges. The transportation process was difficult, and when they came in there, some of the blood had been hemolyzed and it wasn't in any good condition. So I don't think you had the expected results there. So that was the first challenge maintenance of equipment. So even if you had the equipment placed around, say, Kenya, multiple sites there, you still needed to have Becton Dickinson, the company that produced them, to be able to send their service providers there to go around there, because these were very specialized machines that didn't allow for local technicians to go in and do any manipulations there. So was the company able to support all of this? Where at times they did, at times a machine will break down or just not break down, but it wasn't service for months. So that became a problem there.
And maybe looking back now, what were some of the decisions made? How was some of that fixed?
Some of that was fixed, but that very rapidly, it was two ways. I can see this. The companies multiple companies started getting involved in the CD4 business, like the Beckman and others started getting involved in that and producing different simple to use CD4 machines. Becton Dickinson itself moved quickly to developing a smaller point of care test. So it became easier for people to use in the clinic facility without a lot of training, because all it required was to stick in a tube and you wait for 10 minutes and the results will show up and print itself out there. So those changes changed a lot, and they reduced the time from when you did testing and enrollment of patients into ART treatment compared to what it used to be previously.
What about the cost? How was that dealt with?
The cost was still problematic, I would say, because the cost of reagents, the cost of the service contracts were always very high. I mean, how do you maintain service contract machines for these big machines? Now, when you got the point of care machines, yes, they didn't require a lot of service contract machines, but the unit cost was higher than than what you had for the fax count, just because they had to, compensate for their technology. So,
And where did the money come from for that?
the money essentially was donor money. From
Okay.
PEPFAR or the Global Fund. That was, essentially those that were driving those, not necessarily the countries. It might be shifting today, but I think it was mainly donor funding.
So a good investment in terms of laboratory development.
A good investment in terms of expanding technology into remote areas and using them for programmatic engagement and outputs and impact. But unfortunately, the conversation got a little bit confusing because people thought the availability of point-of-care tests meant that you could ignore your laboratory networks in the countries, which is, not true. And there was that, I'll call it that tension for a while until people realized that if you don't have a good laboratory network in the country, you can't properly introduce a point-of-care testing there. So, for example, who's going to evaluate or validate your point-of-care test at national level? So if you brought in a machine, a point-of-care machine for CD4 or viral load, who is going to validate that? Who is going to provide quality assurance there? Who is going to ensure that the test is being done appropriately in the field there? So you needed a network of that, a lab network in the country to work well before you actually introduce appropriately your point-of-care testing.
And then the suggestion of having a national lab strategic plan.
Yeah. Then we started off a movement around 2005, 2006 timeframe, where I remember the very first country that we went to help them develop their national strategic plan was Kenya. And at that time, Ethiopia had developed a national strategic plan for HIV labs. So we're in dialogue with them to convert that into a more broad-based strategic plan for laboratories. Which
exciting.
Yeah, those two countries started off developing, but fast forward as years would go on, we supported about 37 countries in developing their national strategic laboratory plans that were integrated because we were pushing a lot the concept of integration. We cannot just have one HIV lab and then another TB lab. We wanted to use the big three, malaria, tuberculosis, and HIV, to actually develop an integrated lab strategic plan.
When you look back at the PEPFAR days, what would you say you're most proud of? What were the top things accomplished? There were so many, of course.
Strictly from the laboratory standpoint, I would say the period between 2008 and outer years that coincided with the reauthorization of PEPFAR was personally my most exciting years, because we've learned the lessons from PEPFAR 1, which said that one of the lessons was that because of our efforts, we had created silos a lot in countries because we've deeply focused on HIV. So a hospital lab next door that didn't receive PEPFAR funding was almost like in horrible conditions, and then a PEPFAR lab was a lab supported by PEPFAR actually was doing better than that. So in 2008, when Congress reauthorized PEPFAR, there was language there that said it should strengthen systems. And we took that language and ran with it and developed what we call the strengthening of lab management towards accreditation, and then generated a movement in the continent that, was really, really exciting, that we said, look, instead of just looking at proficiency testing, we should look at it in a holistic way. And called a meeting in Kigali, Rwanda in 2009 with WHO and others, and we agreed on what we call a stepwise laboratory improvement process towards accreditation. And today, about 50-something labs, government labs in Africa are accredited, and many more, as of last week, many more, they've gone through the process now, and independently, without PEPFAR support, they are getting to where they are supposed to be. That is really a remarkable achievement, and it's a steep turning point. When we started that in 2009 in partnership with the Clinton Foundation, the American Society for Clinical Pathology, people said, John, you are dreaming that there's no lab in Africa, government lab, that will ever be accredited because the standards were so low. But the situation is very different today. That was a very proud moment for us. And the second proud moment that we had that I can think of is our ability to scale up the diagnostics for infants. When we started this process in 2003, only 3 countries had the ability, PEPFAR-supported countries had the ability to diagnose infants using PCR. Those were Rwanda, South Africa, and Botswana. And years later, after you get multiple countries and multiple labs even within the country being able to do PCR testing, which we couldn't ourselves believe that we'll be able to scale up PCR testing that quickly in Africa, where even basic serology was still a challenge there. So that much was, and because of that, many more children were diagnosed and put on treatment.
So are we talking about the use of dried blood spots? What were some of the key elements of that scale up to enable childhood diagnosis?
The game changer there was the ability to adapt PCR testing to dry blood spot, which is work that we did here extensively with Chenyi. In 1988, Chenyi had published a paper in Science that showed that you could detect a DNA in the cells of infected patients using PCR testing. But that was using whole blood. Now, adapting it to a dry blood spot where you just prick a child's finger and you take a blood spot and then you go to transport it to a reference lab or a more centralized facility and do PCR on it was a game changer because.
So the blood, is it put on a little piece of cardboard or how is it transported?
The blood is first of all a finger or a heel prick is done, and then a tiny blood, about 3 drops of blood are collected from and put on a little piece of paper, what they call the dry blood, the dry filter paper, and transported. Then you just allow it to sit in the room temperature for overnight. It's dried, and you package it well, and you ship it to the reference lab. And then when they receive it, they just punch it, and then you do a PCR testing on it, extract, of course, the DNA, and do a PCR testing on it. So, you could transport many samples. There was no risk of infection. So that dramatically changed the way we approach diagnostics of infants, and especially when we're trying to test them as early as 4 to 6 weeks.
Now, was that methodology used for widespread beyond children, for peripheral sites where it's difficult to get the work done in the periphery? What was the rate limiting aspect of using that technology?
The only challenge that you had, and a significant challenge, was returning the results in a timely fashion back to the clinic so that they could be used in managing the patients.
Okay.
As with new technology, as I've learned over the years, is that you're all excited to get new technology, be it viral load or CD4, but the other end is that the dialogue between the lab and clinic and clinicians doesn't really occur in real time. So that the results were, the PCR results in infants were available. So the labs would test it and put it in the shelves. And it took way longer for the results to leave those shelves and go back to the clinic and to be used for managing the patients. So it's a process that over time, it got improved, but after about 50% of the results were either delayed or actually never went back to the laboratories. But the situation has actually improved a lot today.
Mm-hmm. And the use of cell phones. And
exactly, use of cell phone.
Technology.
Yes, texting.
Well, as we're coming to the end, I guess in looking back, you've had an amazing career. Can you talk a little bit about how CDC contributed or not to this aspect, all of this development? What did we do terrifically? What could we have done better?
I think overall my reflection is is that of gratitude. Personally, my personal gratitude of ever being part of the CDC, because it offered me personally the latitude to really transform myself from a basic scientist into a public health. I didn't go to a school of public health to learn that. I learned public health on the spot, I mean, and by observing people like you and Kevin DeCock and others who actually did public health as such to them. And so that much, CDC provided that enabling environment. I've always, when I mentor people, I tell them that CDC is a great resource too. But don't get carried away by the fact that it allows you do what you want to do, but stay focused and always ask yourself the question, what is my contribution in what I'm doing? I mean, are you really contributing, or are you just being part of the show? I think that is a question that I ask all the time when I'm part of anything. What is your own contribution there? Because CDC has all these resources there. The only limitation that you see at CDC is that it's a very big enterprise. And you may not even know what is going on upstairs. One day, if you finally cross, it may take you 4 years trying to do something that somebody has done already at CDC. So how do you really know about the partnerships, the prospects that exist within CDC? But if you can reach out to people across CDC, it becomes a world of opportunities that exist out there. The only thing I can say for CDC is just to be proud of the work that, as an organization, they did from basic science in HIV. When we started off, we were doing basic HIV work in Thailand and Cote d'Ivoire, and then expanded to 41 countries. And today, PEPFAR is what it is. I would say that half of the success of PEPFAR could be attributed to CDC's engagement using their field experience, their field offices, their commitment to public health there. So I truly think that it has done great. If I had to advise PEPFAR, I would say that they should also think of investing in training senior public health officials in the country the way we used to do before. That is, put a quota where you use your dollars to send some senior people to do public health training in some universities in the US or even within Africa, in Johannesburg, so that you build that level of capacity. We spend a lot of time expecting the countries to show leadership and in managing their program there, but without the people, the seniority and know-how of the people, I think it will continue to be a challenge.
Mm-hmm. Thank you very much.